Rahman Rahim. To start, I would like to thank Professor Dr. Nasr Saeed for his invitation and Zabava. And I would like to thank all the audience here in Egypt and those in Yemen. My talk is about the dilemma of CT interpretation in aortic dissection. Here are the issues that I am going to speak regarding CT interpretation, and I will cover as much as I can from these points. And before starting CT interpretation, we have to know that aortic dissection is the most catastrophic event affecting the aorta, and it belongs to acute aortic syndrome. And these 5 keywords are very important in understanding the aortic dissection. The first word in pathology of aortic dissection is crack initiation, then crack propagation, then medial delamination, and hence intimal flap and false lumen formation, and this raises the liability for further complications. And also, before starting interpreting the CT in aortic dissection, we have to know the classification, which is anatomical, chronological, and clinical classification. Let's go together in the first point in the dilemma of CT interpretation. Before we start interpretation, this is a question. How frequent do we need to do CT in acute aortic dissection? What's your opinion? 1 time, 2 times, 3 times, or more? The answer is at least we need to do it 3 times on admission, second day, and before discharge. We may need to do more if there is evidence of complication. The second point, which is the best view to interpret? Is it the axial, coronal, or the sagittal view, or the 3D reconstruction? Actually, the axial view is the simplest, but we can say that all are complementary. The third point is how does the intimal flap look like in the CT? The intimal flap is a hypodense line separating 2 lumens, an original one which is the true and newly developed one which is the false. The fourth point is how can you find where is the entry tear? We know that the intimal flap in axial view is a complete line from wall to wall. We follow this line up and down in different cuts until we found this line is disrupted. Here is the intimal tear. These are examples of CT showing the intimal tear. While in non-axial view, we have to follow the intimal flap again up and down until this flap is disrupted or this flap comes in proximity to the wall. Here is the intimal tear. We know all that the intimal tear occurs in the ascending aorta in more than 60%, in the descending in about 25%. And the most important question, which is a dilemma really, is where is the true lumen and where is the false lumen? Is it the shape that can determine which of which, or the shade, I mean the density of the contrast, or the site, or the size? There is an example that you know this biconvex lumen is a true one. But when we go down, this biconvex lumen becomes slit-like. So is it the shape? And what about this shape? Which of them is the true and which of them is the false? And what about these identical shapes? Both are D-shaped. So it is not the shape. It could be the contrast, the shade. Yes, one of them is hypo and one of them hyperdense. It could be the density. And what about this? They are of equal density. The flow in both lumens are the same. So it is not the shade. It could be the site. Usually the false lumen is the outer one. What about if we have spiral dissection? So it is the size. Usually the bigger is the false lumen. Actually, even the size, the false lumen starts by small one, and when we go down, it may be more large in size. And the size depends on the extent of dissection. So actually, the shape, the shades, the size do not determine surely which of them is the true and which of them is the false. They are all depend on the site and the size of the entry tier and secondary tiers, and also they depend on the extent of dissection. Then how to know the true lumens from the false lumen? Actually, if we follow non-dissected segment and we found logic continuity, I mean by logic the size, with an undissected segment, this is the true lumen. How can we measure the size of each lumen? This is one way of measuring the size. This is completely wrong. If you need to measure the size of each lumen, you have to go perpendicular to the intimal flap. And this is a diagram showing where exactly to measure the size of the false and true lumen. What is the meaning of having more than 2 lumens in the cut section? If we have 3 lumens, this is triple lumen dissection. Only one of them is true lumen. The others are false lumens. How can this created? This is false and true lumen, and new dissection towards the outer part of the true lumen, and there is another false lumen. But always we have one true lumen. We may have false lumen partition, which is a secondary flap or secondary web that can divide the false lumen into 2 lumens, but always we have only one true lumen. What is the meaning of this branch is arising from the true lumen, and this is arising from the false, and these are arising from both? These are examples for branches arising from true lumen, and this is example for branch arising from the false lumen. By true lumen branch arising from true lumen, this means that there is no extension of dissection to the branch. I mean that the intimal lining of the branch and the true lumen are continuous, while when we take from both true and false, this means that the dissection is going to the ostium with partial disruption, while in the false lumen, this means that the intima of the branch has completely disrupted at the ostium. For the sake of time, I think I have left with a few points. Why left renal arises from the false lumen usually, because the dissection is usually towards the left sides and posterior. Here is the origin of the left renal artery. How can we describe the extent of the dissection? We can describe it by commenting on the entry tear and the proximal and distal extent if we have. How can we predict the high risk for complication? You all know these are the predictors, which are anatomical predictors. What are the criteria for judging the option of treatment? We have 2 complications, which is rupture or malperfusion, and the criteria that judge the option for treatment, they are either we have a possibility of expansion and rupture, so we are going to seal the tear, or they have a possibility of malperfusion, then we are going to do fenestration. I always say that aortic dissection is a disease of no clear catalog, and if you look to the management, sometimes we are going to seal, sometimes we are going to fenestrate. In these examples, I think we are going to seal. And if we are going to seal, the best example nowadays is using covered stent. Please, if you are going to use covered stent in aortic dissection, never use stents with hooks for fixation, and never balloon for sealing. And if we are going to deal with malperfusion, the plan of treatment is not only to reperfuse the malperfused vessels, but to equalize the pressure on either side. And thank you for listening, and sorry for prolongation. Thank you very much.
Thank you, Dr.